Μπορούμε να ξεκινήσουμε.
Καλησπέρα σας. Σας καλωσορίζουμε σε αυτό το πολύ ενδιαφέρον εκπαιδευτικό, στη συνέχεια μάλλον του πολύ ενδιαφέροντος εκπαιδευτικού προγράμματος της Ελληνικής Πνευμονολογικής Εταιρείας, την οποία και ευχαριστούμε θερμά. Θεωρώ και νομίζω ότι έτσι γίνεται, πρέπει να συμπεριλαμβάνεται σε όλα τα εκπαιδευτικά προγράμματα των πανεπιστημιακών και όχι μόνο κλινικών. Σήμερα, αν δεν κάνω λάθος, με αυτό το 2ωρο ολοκληρώνουμε τον ύπνο και ευχαριστούμε πάρα πολύ για ένα υπέροχο πρόγραμμα, τόσο την Ελληνική Πνευμονολογική Εταιρεία, τους συμμετέχοντες και τους προέδρους, αλλά κυρίως την κυρία Ροβίνα Νικολέτα, την αναπληρώτρια καθηγήτρια πνευμονολογίας, η οποία είναι υπεύθυνη από πλευράς ΕΠΕ για αυτό το πάρα πολύ καλά δομημένο πρόγραμμα. Οπότε, πέραν από τον πρόεδρο, το Διοικητικό Συμβούλιο, ένα μεγάλο ευχαριστώ στην Νικολέτα, και προσωπικό αλλά και από πλευράς αυτού του κύκλου του ύπνου, που ήταν πραγματικά up-to-date παρουσιάσεις, και έτσι ελπίζουμε να κλείσουμε και σήμερα. Έχουμε μαζί μας δύο εκλεκτούς προσκεκλημένους. Εσείς μπορείτε, όσοι συμμετέχετε, να γράφετε χρησιμοποιώντας το Q&A ή το chat τις ερωτήσεις σας, τα σχόλιά σας, και θα φροντίσω να τις μεταφέρω στους δύο ομιλητές μας. Και τώρα θα μου επιτρέψετε να περάσω στην αγγλική παρουσίαση, μιας και οι δύο έχουν προσφερθεί να συμμετάσχουν. Δεν είναι προφανώς, όπως καταλαβαίνετε, γνώστες της ελληνικής γλώσσας, αν και αγαπούν πάρα πολύ την Ελλάδα. So, we would like to welcome the two distinguished speakers that we have today with us, and thank them personally and on behalf of the Hellenic Thoracic Society for accepting the invitation and for being with us today. It's Professor Esther Schwarz. Of course, I will start from the females because I'm polite, but also I'm female. It's a close collaborator, a close colleague, both of them. We are collaborating very, very close in the assembly of sleep breathing disorders, the ERS assembly. Esther Schwarz is the current secretary of the assembly, and my successor also, hopefully in the future. And she's also professor of respiratory medicine and lead of sleep disorder centers and ventilation unit in the University of Zurich, the University Hospital of Zurich. And Dries Testelmans is a professor of respiratory and sleep medicine in the University of Leuven in Belgium. He is the current Group 402 chair of our assembly. He is also a member of the board of the e-learning activities, with a long-standing contribution to the educational activities of our assembly within ERS. Both of them are pillars for the Sleep and Breathing Congress, which will take place in April, and I take the advantage to promote this. We need you, and we welcome you, all of you, there. It will be obviously a very interesting Congress, which is the initiative of the collaboration of both societies, CRS and TSRS. It's a highly educational Congress. It will take place in Belgium this time, in the beautiful place of Antwerp. And we will be more than happy to have you there and interact with you. It's a very, very good opportunity for networking as well. Again, thank you so much, Esther and Dries and Esther, for accepting this invitation. It's a great honor for us. And because we know that there is a football game today, very famous one, we will start us up. And I pass the floor to Esther. She will refer to a very, very interesting topic, central sleep apnea accompanied with Cheyne-Stokes breathing. And she will try to cover with a clinical-based presentation, as she's doing always. She's excellent. The topic from pathophysiology to diagnosis and treatment. It's a huge topic by itself, but Esther, as always, will manage it. Thank you so much, Esther, for being with us.
Thank you very much, Sofia, for the kind introduction, and thanks to the Hellenic Thoracic Society, and particularly to you as well for the invitation. It's a great honor and pleasure to be here, particularly in this round with you and Dries. And welcome everybody. Also, thanks to those who will join later or listen it online. And I have to say something to the Hellenic Thoracic Society in person. You are very lucky to have this brilliant woman, Sofia Schίζa, among you. And she's a great friend and mentor for us, for me. So today we're going to speak about central sleep apnea and Cheyne-Stokes breathing, or we're going to start with that topic. And it's worthwhile to do that at this very moment, because we have a lot of new evidence or recent studies that will change our recommendations or the upcoming statements of different respiratory societies on these topics. When we talk about central sleep apnea, it's of course not only Cheyne-Stokes breathing in heart failure. There are, it's a heterogeneous group of different types of central sleep apnea, of central breathing disturbances. But when we consider the relevance in terms of prevalence, then we have certainly central sleep apnea, Cheyne-Stokes breathing in heart failure as an important group of patients with central sleep apnea, also those with treatment emergent central sleep apnea. So a type of central sleep apnea that emerges and sometimes persists during the treatment of obstructive sleep apnea. That can be with CPAP or with non-CPAP treatments as well, mandibular advancement devices, for example. Then particularly in certain areas of the world with a lot of opioid abuse, we have also high prevalence of central sleep apnea due to opioids or other substances. These are, in terms of prevalence, the most relevant. And whenever we see or diagnose central sleep apnea in our sleep labs, it's very important to think about the pathophysiology or to understand it, because only with this we can select the right treatment. And here it's recommended to differentiate between those forms of hypocapnic central sleep apnea. These are or normal capnic, but with a tendency to a low CO2. These are those with an increased ventilatory drive or a high loop gain and unstable ventilatory control. And the Cheyne-Stokes respiration in heart failure belongs to this group. Also the high altitude periodic breathing and treatment emergent central sleep apnea. Then on the other side, we have those with a hypercapnic form of central sleep apnea. These are patients with either a reduced ventilatory drive, like for example opioids, if they have a dampened respiratory drive, central respiratory drive, or those with an impairment to translate the drive to the ventilation, for example, in patients with neuromuscular disease, although they mainly, of course, have obstructive sleep apnea. So tonight we're going to focus on central sleep apnea with Cheyne-Stokes breathing in heart failure. And then we have to briefly think about what heart failure is and which groups we have. And this is the classification of heart failure according to the latest European Society of Cardiology heart failure guidelines. And then we have those with heart failure with reduced ejection fraction, with a left ventricular ejection fraction lower than 40%. And on the other side of the spectrum, those with preserved ejection fraction. So the left ventricular ejection fraction is higher than 50, but they have a diastolic dysfunction or a structural heart disease and other signs and symptoms of heart failure. This used to be different. The cutoff used to be 45%. So some studies that you will see refer to lower than 45% when we talk about an impaired systolic function. And in between, we have those with a mildly reduced ejection fraction. And it's important to consider that ejection fraction is not cardiac output. It's not the same. So patients with heart failure who are at risk for development of central sleep apnea with Cheyne-Stokes breathing are those with a low cardiac output. And on the next slide, we will see that there is also a high prevalence of Cheyne-Stokes breathing in patients with HFpEF, so those with preserved ejection fraction. And when we consider this, we can understand why. So let's think about what cardiac output is. So if we look at the normal heart, patient without heart failure, we may have a filling volume during diastole of, for example, 120 milliliter and a normal ejection fraction with 60%. Then we have a stroke volume of roughly 70 milliliters. If we look to the left, we see a patient with HFrEF, so left ventricular ejection fraction is reduced, 40%, has a normal filling volume, but because the stroke volume is, or the ejection fraction is reduced, we have a lower stroke volume. And on the right, we have a patient with heart failure with preserved ejection fraction. This person may have a small or stiff left ventricle and has a reduced filling volume. But despite the normal ejection fraction, we also have the same reduced stroke volume. And cardiac output is stroke volume times heart rate. So both patients can have, both groups of heart failure can have a low cardiac output. And this is the main reason for, or the risk factor for development of Cheyne-Stokes breathing. There are many epidemiologic studies that look at the prevalence of sleep apnea in heart failure. On the left, you see a large study with roughly 700 people with stable left ventricle, stable HFrEF, so reduced ejection fraction. And here we see that the prevalence of any form of sleep apnea is around, or 3/4 have sleep apnea. A bit more OSA, but more than 1/3 has central sleep apnea. This is also in line with other prevalence studies. On the right side, you see an epidemiologic study or a prevalence study in patients with HFpEF, with diastolic dysfunction, also stable patients. And here you see also the prevalence of sleep apnea of both forms is way higher than in the general population. And the stiffer the ventricle or the more impaired the filling is, the higher the prevalence of central sleep apnea. So it's relevant to consider this in both groups, to think of it. And also because the recommendations how to treat these patients will change probably in the future. It's important that our cardiologist colleagues are aware of the high prevalence of sleep apnea and of what we can do. So it's important that all of us work or collaborate closely with our cardiology colleagues. And we'll let them know about the updates for treatment recommendations. When we think of the prevalence and type of sleep apnea and heart failure, it's also important to consider that this is not stable, or sleep apnea can be dynamic as the heart failure itself. So when we look at the prevalence and type distribution of sleep apnea in HFrEF, HFpEF, and on the right side you see acute decompensated heart failure. You see that the percent of patients with AHI higher than 15, so relevant sleep apnea, increases substantially when patients are decompensated, and also the distribution of OSA and central sleep apnea. And many patients have both, and one or the other form is more dominant depending on how well the heart failure is controlled at the moment. And this is very important for us respiratory and sleep physicians when we think about the treatment approach, and also when we decide when is the best moment to examine these patients, when do we have to do our sleep studies. So probably not during the acute decompensation of the heart failure. What is also well known is that sleep apnea is a worse prognostic factor in patients with heart failure. This holds true for both types of sleep disorder breathing, but is particularly the case for Cheyne-Stokes respiration. I could show you many studies, but here is one with around 1,000 patients with HFrEF who are stable, so not decompensated, and you see that the mortality increases or the survival probability decreases with a higher AHI, and you also see a dose-response relationship with the severity categorization of sleep apnea. So those with severe sleep apnea have the highest mortality. So this is the basic knowledge, or the bottom line, what we all should know about central sleep apnea in heart failure. It's very common in HFrEF and HFpEF. The severity is associated with the severity of heart failure, and therefore the first treatment approach is also the optimization of heart failure. We know that there is a higher mortality in heart failure with Cheyne-Stokes respiration compared to those with the same degree of impairment of left ventricular ejection fraction without Cheyne-Stokes respiration. But we don't completely understand whether there is also a beneficial compensatory response to the low cardiac output with this. Risk factors is very important to know or to be aware of, so that we know who to screen or who to think of. This, it's of course more severe heart failure, lower left ventricular ejection fraction, but think back on the role of cardiac output, so it's mainly the low cardiac output, lower the cardiac output. And atrial fibrillation is a risk factor, and the more irregular the ventricular frequency or the heart rate is, the more likely to have Cheyne-Stokes respiration. Advanced age, the male gender, this has something to do with the loop gain and the chemosensitivity, which is higher usually in males, and the more hypocapnic the patients are, also during daytime, the higher the risk. It's not only present during sleep, you can also see that sometimes in patients while they're awake, and particularly during exercise. The symptoms is of course important for us to know and to assess in these patients, because we want to treat them to improve symptoms, and they can be similar like for patients with obstructive sleep apnea. They can be asymptomatic or minimal symptomatic. They can suffer from sleep fragmentation. This is very common, and also choking is common in patients with Cheyne-Stokes respiration. If you have a long apnea, the airway may also collapse, and insomnia and poor sleep quality. And of course, the nocturnal dyspnea and the orthopnea. So when we have to define or say what is Cheyne-Stokes respiration, and nowadays it's recommended to use this term primarily when we speak about Cheyne-Stokes periodic central sleep apnea with periodic breathing in heart failure, although it was described in different situations first. This was the Scottish and Irish doctors, John Hunter, Joan Chaney, and William Stokes, who first described this in the 18th and early 19th century. They described this pattern of breathing with central apneas and hyperventilation or waxing and waning pattern in patients close to death. But now it's recommended to use it specifically only in heart failure. So it's a periodic breathing in which central apneas, or it can also be central hypopneas, alternate with phases of hyperpnea. They also result in hyperventilation. And we have this classical waxing and waning or crescendo pattern in patients with a low cardiac output and a prolonged circulation time. This is the AASM, so American Academy of Sleep Medicine definition. When we want to score this during sleep studies, we do this in a 10-minute window compared to the 5-minute window that we usually use to score other respiratory events in USA, for example. So periodic breathing with at least 3 consecutive central apneas or hypopneas, with in between this crescendo, decrescendo hyperventilation pattern. And compared to other types of central sleep apnea, we often have a longer cycle time. And the cycle time means, you see that here on the right side, the apnea or the hypopnea together with the hyperventilation phase in between. And of course, the more prolonged the circulation time, the lower the cardiac output, the longer the cycle time of in Cheyne-Stokes respiration. This is very, very classic with this crescendo, decrescendo, so waxing and waning. So you can see that immediately when you look at the sleep study. There are the mechanisms, if you want to explain that. So we have several contributing factors. One is that hyperventilation stimulates the mechanoreceptors in the lungs and particularly the pulmonary vessels. And these patients have an increased CO2 sensitivity of the chemoreceptors. and the increased chemoreceptor response to CO2 results in this ventilatory instability. The prolonged circulation time, so from the heart output until it's in the central, in the respiratory center in the medulla, or also the peripheral chemoreceptors plays a role, and the loop gain. And we're going to look in a minute at loop gain to understand this and what loop gains means. It's a term that comes actually from electrical science, and it's about feedback, loop feedback response. It's defined by the response ratio to the disturbance. And we have this circulus vitiosus. It's important to consider this when we think about the treatment approaches. So we have a central apnea or a central hypopnea. This results in a small increase in CO2 and, of course, also a decrease in the partial pressure of O2. This then stimulates the chemoreceptors. And then we have this excessive reaction. So we have a disturbance and a high or excessive response to that. And during this excessive hyperventilation, we also have the arousal, not like in an obstructive apnea where the arousal is at the apnea termination. We have in this type of breathing disorder, we're having during the hyperventilation phase, and this is then another stimuli. So we have chemoreceptor and arousal stimulation, which results in this increased ventilatory response. And if we have a patient with a high loop gain, so a patient who has an increased response to a disturbance, of course, we want to avoid the disturbance so that he or she doesn't have this increased response. So we have to avoid the central apnea. We're going to see that when we talk about the treatments. And loop gain, for those who want to know it in more detail, this has several components. We have the controller gain. This is nothing else but the chemosensitivity, so how much we change our ventilation response to a change in CO2. Then we have the plant gain part. This is more what the lungs do. So when we change our ventilation, how much it affects the CO2, the partial pressure of CO2. And then we also have the circulation time feedback gain. And when we think about the ventilatory response, so it's different when we are awake compared to sleep, and also different in REM sleep and non-REM sleep. When we first think about the hypercapnic ventilatory response, see that on the right. So how much do we change our ventilation in response to an increasing CO2? You see that the slope is very steep when we are awake, and it flattens or is less than 50% during REM sleep. And from this, we can conclude that those types of central sleep apnea that are associated with a high loop gain, so like Cheyne-Stokes respiration in heart failure, or patients are more prone to that during non-REM sleep than during REM sleep. It's the different to obstructive sleep apnea. So when we stop with the pathophysiology and start with the treatment approaches, so we want to avoid central sleep apnea. To control this, then I would like to show you a few RCTs and also non-RCT data that are the basis for the current treatment recommendations. And the first randomized controlled trial in this field was in patients with Cheyne-Stokes respiration in systolic heart failure. It was the CANPAP trial. So constant CPAP that has been available since 1981, first for patients with obstructive sleep apnea, of course, was used first. So in this CANPAP trial, we had roughly 260 patients with severe systolic heart failure. You can see here on the left that they really had a severely impaired left ventricular ejection fraction lower than 30%. They had dominant central sleep apnea with an AHI of 40. And half of them was randomized to CPAP, constant CPAP. That was a median pressure of 10 centimeters of water, and the other half was in the control group. All had best optimal heart failure treatment, and the outcome was transplant-free survival. Study duration 5 years, and a bit disappointing was that there was no effect of constant CPAP on the transplant-free survival. But when we looked at when one looked at the sleep studies, it was seen that AHI was only reduced from 40 to 20. So that means there are responders and non-responders. Patients with an AHI higher than 15 were included. So they did a post hoc analysis and defined CPAP response when the AHI was suppressed to lower than 15 events per hour. So what was the initial inclusion criterion? And when they then compared the responders, which had relatively good response to CPAP, with the non-responders, they saw that the transplant-free survival was better in those with controlled central sleep apnea. But of course, it was only a post hoc analysis. But constant CPAP is what is currently used, often as a first-line treatment in patients with symptomatic Cheyne-Stokes breathing and heart failure. But since the late 90s, we have another positive pressure therapy, and this is adaptive servo ventilation. The first study in patients with heart failure was published in 2001. And this therapy is way more effective in controlling periodic breathing of the type Cheyne-Stokes respiration. And it's a very intelligent algorithm adapting the pressure support breath by breath in a way that is anticyclic to the effort of the patient. Here below you see the pressure, the support that is increasing when the effort and the flow are decreasing. And compared to non-invasive ventilation that we use in patients with hypoventilation syndromes, these devices, they adjust their pressure support breath by breath. We have several aspects. We have an expiratory pressure. This can be fixed or also automatic, like in an auto CPAP device to control OSA. And if we think back, that these patients very often have both central sleep apnea and Cheyne-Stokes respiration, this makes sense. Then we have the auto-adjusting inspiratory pressure support. So whenever they have a central hypopnea or central apnea, we can give them pressure support. And they also have a backup rate. So it's very effective in controlling periodic breathing with the Cheyne-Stokes respiration, and can also control obstructive sleep apnea. Here you see that from a sleep study, and for those who are interested in the details of how this works and the algorithms, I would recommend this publication by Shahrukh Javaheri. It's also highlights the different algorithms by different companies. If you work in this field and use ASV, prescribe ASV, you may have the opportunity to work with different companies or different devices, and then we should know the differences between these algorithms. But this is only for those who want to know it in detail. Then, of course, after realizing that this is the most effective treatment for Cheyne-Stokes respiration, it was necessary to do an RCT in patients with heart failure. And then here we have this famous SURF-HF trial. It was a study like the CANPAP in patients with systolic heart failure, so with HFrEF, LVOF lower than 45%, and they also had predominant central sleep apnea. It was a very large study with more than 1,000 patients and had a combined endpoint. So the combined endpoint was the time to the first event of either death or mortality, cardiovascular mortality, life-saving intervention, or hospitalization for heart failure. And this trial, unfortunately, had to be stopped early because the interim analysis, there was a safety signal in the interim analysis. But when we look at the primary endpoint, there was no difference between the ASV group and the control group. But when we look at the sub-outcomes, or cardiovascular mortality, they saw in the interim analysis that there was an increased cardiovascular mortality in the ASV arm compared to the control group. There was a 2.5 absolute increased risk per year of higher cardiovascular mortality. But you can imagine that it's very difficult in such a vulnerable patient group to perform such a large RCT, and there were also many problems. So one quarter of the patients was treated against randomization, and the treatment adherence was very low. So the most patients who were randomized to ASB used it not, or less than 3 hours. that's why the authors did a so-called on-treatment analysis, but unfortunately this came to the same result like the intention to treat analysis, so strong signal. And when try to find out what happened, why the mortality was increased, they saw that it was mostly a sudden cardiac death, so not a patient who was hospitalized for decompensated heart failure, but sudden cardiac death, and mainly in the group with very severe heart failure with a left ventricular ejection fraction lower than 30%. And this randomized controlled trial then, of course, resulted in the change of the recommendations for this patient group. So the colleagues from cardiology, the ESC, European Society of Cardiology, in their 2017 heart failure recommendation stated that ASV is not recommended in patients with HFrEF and predominantly central sleep apnea because of this study. And this was in the next version of the European Society of Cardiology heart failure guideline. The statement was repeated. So no use of ASV in patients with HFrEF and predominant CSA. We don't have data for HFpEF, and the statement was not for patients with OSA, of course, only for this group. But while the SURF-HF trial was was published, there was another important RCT that was ongoing, and this was the ADVENT-HF. This was also a multi-center randomized controlled trial in patients with HFrEF, so reduced systolic function. It was led from Toronto, but European centers were also involved. And the difference to the other study is when we look at the inclusion criteria, that they included patients with HFrEF with an AHA higher than 15 with both OSA and or central sleep apnea. So also patients with obstructive sleep apnea, but only, as always in this trial, with a long follow-up time, non-sleepy OSA. And they used also a different device. So this device had a variable pressure support that was more effective in controlling OSA. In the first study, in the SURF-HF, it was a fixed EPAP, and they had a minimal pressure support of 0. And when you think of that these patients have these hyperventilation phases and are hypocapnic already, it's very important that the pressure support is not applied during the hyperventilation phase. So it's a different device as well. And this study, it's unbelievable. It also had to be terminated early, but absolutely not because there was a safety signal. So there was no safety signal. The reason was the pandemic. So it was difficult for the colleagues who ran this study to recruit and follow up new patients. And there was also the Philips device recall because it was a Philips device. For those working in sleep medicine, you might be aware of this device recall in the United States and in Canada because of the foam degradation. So the study was stopped early. At this time, they had recruited 85% of the planned sample size, still a large study with more than 700 patients. But unfortunately, three quarters were OSA. They were not able to recruit so many CSA patients, Cheyne-Stokes respiration, as planned, not even half of them. This was also because some centers did not allow to, or some countries did not allow to recruit these patients because of the SURF-HF trial, of course. The first important thing to say is compared to CPAP or the CAMPAP trial, ASV was able to control both forms of sleep apnea perfectly. And here you see the primary outcome. Again, this combined outpoint, and ASV had no effect on the primary outcome. So there was in no direction. So there was also no harm observed in the ASV arm compared to the control group. And when we look specifically at mortality as part of the primary outcome, you also see that ASV had no effect on mortality. There was no difference between the control group and the ASV arm. And then now it's interesting to look at mortality specifically in the OSA group. That was 3/4 of the patient, and the small CSA group. And here was also no significant effect of ASV in one of the groups, but you see a tendency for beneficial effect of ASV in the central sleep apnea group. But we can't make no conclusion from that because it's not statistic. The study was not statistically powered to address mortality in the subgroup. but at least there is absolutely no sign of harm. And of course, for our patients with severe heart failure, maybe survival is not the only or not the most important outcome. They have a bad sleep quality, usually impaired quality of life, and a very fragmented sleep with a lot of arousals and a lot of light sleep. And there was a beneficial effect of ASV in these heart failure patients in both groups on sleep architecture. So it reduced light sleep and increased slow wave sleep, deep sleep. The arousal index was reduced, sleepiness was reduced, and the quality of life improved. And this signal was even stronger in the central sleep apnea group. So the authors concluded from these results that although there is no significant effect of ASV on the combined cardiovascular endpoint and mortality, there is that the therapy could be used safely, and there is a beneficial effect on relevant patient-reported outcomes, sleep quality, quality of life, and symptoms. This signal was particularly strong in the central sleep apnea group. And when we think of the difficulty of running RCTs in such a vulnerable patient group population, it's also clearer in general that in RCTs we always have an extremely selected patient population that may not be representative for those patients that we have in our sleep clinics or that we treat. And that's why it's also important, or not only that's why, but that's one of the reasons why it's also important to consider other study types, so observational studies or real-world data. And here you'll see published in 2024, an important observational study from our colleagues in France. It's a prospective cohort study called the PHASE trial. It's like an ASV registry. So they followed patients on ASV with heart failure of both types. So HFpEF is also represented here, not only HFrEF, with predominant central sleep apnea plus minus obstructive sleep apnea. And these heart failure patients, of course, are also not just one group. They are also very heterogeneous. We have different phenotypes, and they identified 6 clusters. You see them in the graph on the right. You see at the bottom are those with more OSA, and above those with more CSA. On the left, those with HFrEF, and on the right, those with HFpEF. So the cluster that was studied in the SURF study with the increased mortality was the cluster 1, so HFrEF and predominant central sleep apnea. And as control group, they used those patients that in clinical practice refused adaptive servo ventilation or discontinued it within the first 3 months of treatment. And now we have the follow-up data after 2 years. And the first finding was that in general, when we look at the whole group, that the ASV seems to have a protective effect in survival in these patients with heart failure and predominant central sleep apnea, plus minus obstructive sleep apnea. But the outcome was very different in the different clusters and in these different phenotypes. You see here the red curve on this is the HFrEF with central sleep apnea, like in the SAFE trial. So they had the worst prognosis, and ASV had no impact on survival, neither in a good nor a bad direction in this cluster 1, 2, and 3. If you look back, see here, it's those with HFrEF mainly. But there was a beneficial effect of ASV on survival in all the other clusters, so cluster 4, 5, and 6. If we look back, we see it's those with HFpEF, also diastolic heart failure, and in those with strong nocturnal intermittent hypoxemia. So the conclusion from this 2-year follow-up of this prospective observational study was on the one hand, that in general ASV has a beneficial effect on event-free survival compared to the control group in patients with heart failure and with predominant central sleep apnea, and that they identified 2 specific subgroups that have will benefit particularly, and that's important for us to know. It's those patients with HFpEF. And unfortunately, we don't have a RCT in this, but at least this helpful data. And the other patient group that may benefit particularly from ASV is those with severe intermittent hypoxemia. So that was the clinically helpful conclusion from this important study. That's how the treatment recommendations looked like in 2017 when the European Respiratory Society had their statement or recommendation for central sleep apnea syndromes. We are here on the left side now in heart failure. Patients with HFpEF or at that time with preserved ejection fraction higher than 45 should be first treated with CPAP if they have symptomatic central sleep apnea. And if CPAP is not effective in controlling central sleep apnea, then we have the option to use ASV as a second treatment approach. But the problem was in those with impaired systolic function, if they had predominant central sleep apnea, of course symptomatic, that's why we treat them, and CPAP failed, then it is at the moment not recommended to use ASV, and we had also no other treatment that was evidence-based. I didn't mention for time reasons, also and to keep it a bit more general, the other treatment approaches that we have recent RCTs, for example, transvenous phrenic stimulation. If you think back that you want to avoid central sleep apnea, this is also an intelligent approach. If you stimulate there's a unilateral stimulation of the diaphragm, you can also avoid central sleep apnea. And for oxygen, we also have ongoing studies. And of course, oxygen is sometimes used in clinical practice already. That's how it could look in the future when we consider all the new evidence. So HFrEF on the left side, the same pathway, first CPAP, if not effective, we should stop it. That has always been true. If the patient has no benefit and it doesn't control central sleep apnea, what we will do in the future with patients that do not respond to CPAP, it's currently discussed whether, based on the new evidence, whether the field should be open again for ASV. And at the moment, there is an ongoing ERS task force with Sofia as chair, and with Winfried Randerath in the lead. And this is a reconsideration of the current recommendations, because at the moment we can say that there is no evidence for a negative effect of the new ASV devices that are titrated properly on MACE and survival in HFrEF. But we know from the ADVENT trial that there are beneficial effects on patient-reported outcomes. So it's currently discussed, but it's under construction. It's not out yet, and the colleagues in the North America and Canada will also, the respiratory societies, come up with new recommendations or update. And this is justified. What will be very important in general is that we titrate properly and think of the hypocapnia as well. And this was stated in 2015, but it's still true. So although the ASV devices are very intelligent and titrate themselves automatically, it's recommended to do in-laboratory titration, first to confirm the efficacy in controlling sleep apnea, but also for safety reasons. And if you think that it's a breath-by-breath adaptation, it's clear that mask leak is a particular problem, even more than in other types of positive airway pressure. So proper titration and monitoring was always important and will be in the future. So when I can summarize the treatment recommendations for central sleep apnea in heart failure in 2025, then of course we have first the optimization of heart failure treatment. This can be drugs or devices like resynchronization therapy, heart transplantation. And we should only treat patients with Cheyne-Stokes respiration if they are symptomatic, not just to correct slightly elevated AHI. CPAP is the first evidence-based treatment approach, but we know that it's a constant CPAP, that it's only effective in a subgroup of patients, maybe half of them or even less. And we should only continue it if it really is effective in controlling sleep apnea and the patient has a benefit. At the moment, ASV is only recommended in HFpEF. We know it's way more effective in controlling central sleep apnea of the type Cheyne-Stokes respiration, but probably this will be different in the future when we consider new evidence. So if keep that in mind and check the changes, the next publication, so that you will be able to communicate that in your hospitals with your to your cardiologist, and to maybe develop new pathways for these patients, because we have a lot of symptomatic untreated patients. Then there are ongoing studies for nocturnal oxygen, and also for transvenous diaphragmatic pacing. And if I have time, I would have cases. First of all, I thank you for bearing being here and listening to me, and particularly to Sofia. And it's up to you, Sofia, to decide whether I shall continue with the case or we go for questions. The turn of my life.
Well, Esther, first of all, thank you so much for this excellent presentation. The topic is huge. However, given that you are extremely modest person as well, I know that. I have to say that in this task force that is ongoing, and we are expecting some good things related to ASV. Esther is a chair also. I am co-chairing, and the lead is Winfried Raderath is leading. And Esther is an expert in this field, a real expert. And I have learned a lot from her and also from Winfried. And may I ask you something? And I think that maybe because maybe the case also will be interesting for our participants. But before moving to one case, just one, I know that you have two, but you can present the one case. Can I ask you, because we are hospitalizing patients with respiratory diseases and comorbid and cardiac failure very frequently. And of course, as you mentioned, preserved heart failure with preserved ejection fraction has is a phenotype with a better response to ASV. If the patient, of course, has a high suspicion or verified central sleep apnea with Cheyne-Stokes breathing. So can you sum up a little bit what are the most important clinical features that we can expect from a hospitalized patient in our respiratory units that can increase our suspicions for potential central sleep apnea, Cheyne-Stokes breathing, and refer for further sleep evaluation to the sleep expert? And also thank you so much for mentioning in this presentation that ASV needs in-laboratory titration with careful mask fitting and beat-to-beat, breath beat-to-beat titration also. Otherwise, will be a mode of treatment that can cause harm in the patient if it's not proper titrated in lab. And thank you for this. Esther.
Thank you very much. What you last said is really extremely important, not just because of the hypocapnia, and we don't want to increase that. Usually patient become more normocapnic when we treat them with ASV, but also because of the potentially adverse hemodynamic effects in these patients. They are very vulnerable to all types of positive pressure therapy. So you mentioned the signs, you mean symptoms and signs or risk factors in which patients we have to think of. So yeah. When they are hospitalized because of decompensated heart failure, it's usually not the right time to do a sleep study, but we always have to think of before did they already have, or is the suspicion high that before the decompensation they already had a relevant sleep disorder briefing. And also OSA is important. We always ask to do the comprehensive evaluation whether they are at risk for OSA, because this will still be there. If they are hypocapnic, if they have in the blood gas analysis. I mean, if they have a very restrictive feeling, if they have a severe systolic heart failure, if they have the typical history of with choking, fragmented sleep, all these patients with atrial fibrillation, particularly older males, these are the patients at risk. And we usually recommend, sometimes it's so bad that we have to do a treatment approach during the hospitalization. And there is also data that the mortality of these patients, of course, is increased. This was one of the first studies in this field in acute decompensated heart failure, but usually we try to optimize everything and then schedule them at the later point to better see the type of sleep apnea they really have. Not sure whether this answered your question or did you think of something else?
No. Only that we don't have data, of course, for differences between males and females, unfortunately, and they are usually less sleepy than the typical obstructive sleep apnea patient, even though we know that there is a non-sleepy phenotype in OSA as well, and difficulties mainly maintaining sleep potentially. And there is another very quick question from a participant. In patients with heart failure, is the sleep parameter taken into consideration for the kind of phenotype and kind of treatment? I guess that because I don't know who is anonymous, I guess that is referring to the results of the sleep study.
Of the phase study, you mean? Or?
No. He or she asked if in patients with heart failure, in order to phenotyping them and assign to the treatment then based on the phenotype, if we take into account the sleep parameter.
Of course, the sleep study parameters, if this is meant, yes, of course. And the longer the cycle time, the less likely is that they respond to CPAP well, for example, whether they are very hypocapnic or how much obstructive sleep apnea, and that's all something we consider, of course, in treatment selection, and also when we think about the settings of the ASV device when we start titration.
Okay. Esther, maybe another option that we can have, because we need to be flexible. How quick is your the case presentation?
How long it takes?
How long it takes?
Less than 5 minutes.
Okay, please proceed. It will be interesting to hear that, and then we will move to this. Please proceed, Esther.
Thank you very much. I think the first case is probably a common scenario for the future. Sometimes we see these patients, or we first meet them in the hospital and sleep clinic when they are already on CPAP, and we see that maybe CPAP was started for OSA, and then during the course they develop central sleep apnea because they develop heart failure. And this scenario is something that may happen more often in the future, that we change them to ASV when we can. So this is a 76-year-old man. He has been on CPAP for OSA since 1982. I met him a few months ago, and it was very interesting because he has been on CPAP for 40 years. He knew everything about the old devices. We don't have the records from the first diagnosis, but he said it was severe symptomatic OSA. He's ever since happy on CPAP, so for more than 40 years. But last year he developed more daytime sleepiness and sleep fragmentation, while using CPAP. Then his respiratory physician in practice, who was treating him with the CPAP, saw that the CPAP statistics said there is a high residual apnea-hypopnea index, and sent him to us, to our sleep center. We knew about the patient that he had a valvular and rhythmogenic heart disease, permanent atrial fibrillation, and he had the left ventricular ejection fraction around 45. Maybe it was somewhere between 40 and 45. You see the drugs on the left side. So he had advanced heart failure treatment with many different medications. You see the arterial blood gas analysis during wakefulness, and here you can already see that he's hypocapnic also when awake. So from everything we know, it's a very high suspicion that this is Cheyne-Stokes breathing or central sleep apnea. Here you see his CPAP usage pattern, and this is also classical, like Sofia mentioned about the sleep pattern of these patients, that they have a very fragmented and bad sleep quality, and you see that from his usage pattern, device on, off, several times per night. And he had also nocturia very often. This increased in the last year as well. So he had auto CPAP, 9 to 15 centimeters of waters. You see that there was no relevant leakage when we look at the device statistics, and also the CPAP device said, okay, it's Cheyne-Stokes respiration. We did then a sleep study in the sleep lab, not a polysomnography, but a polygraphy with capnometry on CPAP. And we saw that he had a hypocapnic type of central sleep apnea with a high apnea-hypopnea index of 47 events per hour. And you see that the mean nocturnal PCO2 was only 4.7. He had atrial fibrillation all night. Here you see a 10-minute window. It looks a bit different because the flow signal here comes from the CPAP device. It was on CPAP. You see the respiratory effort, but you see the waxing and waning pattern and the cycle time of roughly 1 minute. Periodic cyclic desaturations lower than 90%. And then we decided to change him from CPAP to ASV. Discussed this with him. You see the guy, he was happy to, in his case, to be used. You see he's also not a very lean person, so big guy. And he had severe obstructive sleep apnea of CPAP. So we started him on ASV with a daytime titration first in the sleep lab, also with polygraphy capnometry setup. And here you see the first minutes. So we started you see that on the 2 o'clock in the afternoon. And whenever you see this pressure support coming, then it's a mandatory breath with pressure support during the central hypopnea. And this was very often the case in the first minutes. Then you see 5 minutes later or 7 minutes later, you also have already a way more stable breathing, less backup breaths with pressure support. Sorry that it's in German, but Druck means here the pressure. And then 19 minutes after starting the titration, the guy is asleep. Here you see him have an absolutely stable breathing, no central sleep apnea anymore. So it was very effective and fast in stabilizing breathing. Then we kept him overnight in the sleep lab. And you see here the results from the sleep study. So no elevated AHI anywhere, more or less normal oxygen saturation, and the CO2 is also a bit higher. And what is also interesting is if you look at this in the first night, the usage pattern, he never turned it off. So he had a consolidated sleep. So this demonstrates also the effects that have been seen in the Advent trial. And I will see him in 2 weeks to see how it goes at home. But this is a successful ASV treatment and switch a patient with mildly reduced ejection fraction that has been switched from CPAP to ASV because of uncontrolled Cheyne-Stokes breathing on CPAP. Of course, he had auto CPAP, but it was clear that it would not be effective to change this to constant CPAP because this would usually be the first step or the first recommendation.
Thank you so much, Esther. It was highly educated, this case presentation as well, because shows also that the close follow-up of the patients may reveal the real problems, and we have to solve these problems but in a stepwise approach. And thank you so much for this. And once again, thank you for your contribution to this educational webinar initiated by Hellenic Thoracic Society. Thank you, Esther.
Thank you very much. Thanks.
And now we are moving to our other speaker, Professor Dries Testelmans. Dries will deal with a very another important topic, holistic approach of hypoventilation syndromes. But the topic is huge; it's a congress by itself. So Dries. We spoke with Dries that he may focus mainly to neuromuscular, obesity, hypoventilation, and chest wall disorders. Again, it's a huge topic, but I know very well Dries, and I think that I am more than sure that we will enjoy his presentation and we will learn a lot. Thank you, Dries, for your contribution again and for accepting this invitation.
Thank you, Sofia, for this very nice introduction. And I would also like to thank the Hellenic Thoracic Society for the invitation, and especially Professor Schizza for this very nice invitation to contribute to this webinar and this course. So I will talk about hypoventilation syndromes, and I will try to keep it also as clinical as possible. I don't have any potential conflicts to disclose at the beginning of my presentation. And I would like to start by giving you an overview of the different types of nocturnal or sleep-related hypoventilation syndromes that are mentioned in the International Classification of Sleep Disorders, which is the Bible for the sleep medicine specialists. And I will talk mainly today about two types of sleep-related hypoventilation. The first is sleep-related hypoventilation due to a medical disorder. And we will focus on neuromuscular disorders and chest wall disorders. And at the end, I will briefly say something about COPD. And the other type of hypoventilation that I will talk about is obesity hypoventilation syndrome, which also occurs during sleep, of course, but here we also often see daytime hypoventilation. And what is important that in all these sleep-related hypoventilation syndromes, that you need especially an increase of the CO2. And here you see the ASM definition for hypoventilation or nocturnal hypoventilation, which is an increase of the PaCO2 to more than 55 millimeters of mercury for more than 10 minutes during the night, or an increase of the PaCO2 with more than 10 millimeters of mercury to a value higher than 50 millimeters of mercury for more than 10 minutes. So these are the actually ASM definitions to define nocturnal or sleep-related hypoventilation. Let's start with some chest wall disorders that could lead to nocturnal respiratory failure or nocturnal hypoventilation. And here are some examples. Kyphoscoliosis is an important reason or an important underlying condition that could lead to hypoventilation, but also ankylosing spondylitis, thoracoplasty, fibrothorax, chest wall tumors, or morbid obesity could contribute to nocturnal hypoventilation. And all these chest wall disorders are characterized by a reduction of the respiratory system compliance. On the other hand, we have different neuromuscular disorders. And neuromuscular disorders is actually an umbrella of several individual neuromuscular diseases. And usually these diseases are defined or are categorized by the location where the problem arises in the body. And you can have different neuromuscular disorders, for example, with a problem at the level of the motor neuron, like amyotrophic lateral sclerosis, or you can have problems at the level of the plexus or the peripheral nerve. You can have a problem at the neuromuscular junction, or you can have problems at the level of the muscle, for example, in patients with Duchenne muscular dystrophy. But on the other hand, you can also make a different categorization. You can also define different neuromuscular disorders leading to different types of respiratory insufficiency. And on the left top, you see some of the neuromuscular disorders that lead to or can lead to acute failure. And these include Guillain-Barré syndrome and myasthenia gravis. So if you have a patient with these two types of neuromuscular disorders, this will usually lead to an acute onset of respiratory failure with a presence at the emergency department. On the other hand, you have several neuromuscular disorders that usually lead to a variable progressive respiratory failure or chronic respiratory failure. And these disorders include Steiner disease, myotonic dystrophia type 1, limb-girdle muscular dystrophies, SMA type 2 or 3, post-polio syndrome, Charcot-Marie-Tooth disease, and so on. So variable, slowly progressive course. And then you have the neuromuscular disorders with usually a rapidly progressive or fatal course of chronic respiratory failure. And these include amyotrophic lateral sclerosis, SMA type 1, and Duchenne muscular dystrophy. So usually in progressive neuromuscular disorders, there is progressive muscle weakness. And as already mentioned, in some of these neuromuscular disorders, also the respiratory muscles can be affected. And this leads at a certain point to the presence of inspiratory muscle weakness. Inspiratory muscle weakness will lead to a decrease of the vital capacity and a reduction of the tidal volume. And this could contribute to development of atelectasis of the lung and will increase the work of breathing in these patients. On the other hand, respiratory muscle weakness will lead to tachypnea, which will also contribute to a higher work of breathing. And tachypnea will also lead to a decreased blood flow to the respiratory muscles because the expiratory part of the respiratory cycle will be reduced. The combination of increased work of breathing and decreased blood flow to the respiratory muscles could lead to respiratory muscle fatigue and the development of hypercapnic respiratory failure. On the other hand, atelectasis could lead to ventilation perfusion mismatch and hypoxemia and will contribute to hypoxemic respiratory failure. Besides inspiratory muscle weakness, patients can also have expiratory muscle weakness, which will lead to impaired cough and clearance of secretions, contributing to atelectasis, the increased amount and work of breathing, and hypoxemic respiratory failure. When do we see respiratory failure or hypoventilation in patients with these progressive neuromuscular disorders? Well, we see the first occurrence during rapid eye movement sleep. And why is this? Because during our sleep, the chemosensitivity, the sensitivity of our chemoreceptors at the large vessels and at the brainstem will be somewhat reduced. And this is also the case for normal subjects. So during sleep, a reduced chemosensitivity. During sleep, there will also be an increase of the upper airway resistance because you all know that the chance of having apneas increases during our sleep. And this could be increased in patients with bulbar affection, like some ALS patients who have bulbar dysfunction. This could lead to a higher increase of the upper airway resistance. And then we see it first during rapid eye movement sleep because you know that during rapid eye movement sleep, there is a partial paralysis of our muscles and all the work of breathing need to be performed by the diaphragm. And when the diaphragm is weaker, you will get you will have troubles during that part of the night. And here you see an example of a patient with amyotrophic lateral sclerosis who is really in the first stage of respiratory failure. We only see problems during rapid eye movement sleep. Here you see the hypnogram of this patient, and the thick line are the rapid eye movement sleep episodes. You see the nocturnal oxygenation, and you see that it's stable with some slight fluctuations during rapid eye movement sleep. And here you see the transcutaneous PCO2, which is also stable overnight, but there is an increase of the PCO2 only during rapid eye movement sleep. So really the first beginning of respiratory failure only here during rapid eye movement sleep. If patients progress, then of course respiratory muscle weakness will get worse, but also other factors could play a role in the progression of respiratory failure. If these patients have periods of sleep-induced hypoventilation, as already discussed, this will lead to an increase of the CO2 and reduction of oxygen during certain periods of the night. And this increase in CO2 and reduction in oxygen will stimulate the chemoreceptors of these patients. The chemoreceptors will try to increase the breathing, but in patients with neuromuscular disorders, does not always work, and they will get awake and they will get aroused from sleep, so they will wake up. This, if this happens frequently, can lead to sleep fragmentation, and if your sleep is fragmented, there will be an increased tendency to sleep also during daytime, and this will increase again the periods of sleep-induced hypoventilation. If after further progression, these periods become very frequently, then the chemoreceptors in the end will say, okay, now it's enough, we have to adapt, and they will increase the threshold to increase the breathing pattern. So there is a diminished chemoreceptor function and a depression of the respiratory drive, and this could contribute to progressive respiratory failure, now not only during sleep, but also occurring during awake states. So this is the usual progression. We have hypoventilation during rapid eye movement sleep. If we progress further, we have hypoventilation during the whole sleep. And then in the end, you can also have daytime respiratory failure. For patients with slowly progressive neuromuscular disorders and also for fastly progressive neuromuscular disorders, it's important to determine the moment when hypoventilation occurs because we want to offer them treatment. And it's not always easy to determine the exact moment when these patients have hypoventilation. So therefore, we should look for symptoms, and we can look to general symptoms like fatigue, poor appetite, hallucinations, or confusion. Of course, we have to look to respiratory-related symptoms like breathlessness, orthopnea, coughing, recurrent chest infections. Sleep-related symptoms, because if they hypoventilate during sleep, there will be a disturbed sleep or a non-refreshing sleep. Daytime sleepiness can be present. And then you have less specific symptoms like swallowing disorders or voice changes. Some years ago, this questionnaire was developed, which is the motor neuron disease dyspnea scale, where with a few questions, you could estimate whether hypoventilation is present or whether there is a higher risk that the patient has hypoventilation. And for this questionnaire, a score of equal or more than 2 had a sensitivity of 75% to predict whether there was hypoventilation. However, the authors say that this, of course, should be combined with other tests like respiratory function measurements. So besides symptoms and questionnaires, we can perform other diagnostic methods to estimate the moment or the timing of hypoventilation or respiratory failure. And these diagnostic methods include lung function parameters like the vital capacity. And I will not go into detail in the exact cutoffs, but if you have a vital capacity lower than 50%, then there is a quite high chance that your patient has nocturnal hypoventilation in these progressive neuromuscular disorders. You could perform respiratory muscle strength measurements like the maximal inspiratory pressure or the sniff nasal inspiratory pressure with specific cutoffs pointing out a higher risk that there is nocturnal hypoventilation. Diaphragm ultrasound is a quite newer tool, but it's not yet standardized, or no standardized cutoffs are available at this moment, but it could help to evaluate the functioning of the diaphragm and the presence of hypoventilation. And then, of course, you could perform nocturnal measurements of oxygen and transcutaneous CO2, or a sleep study could be performed, either a polygraphy or a polysomnography, to evaluate the presence of nocturnal hypoventilation. We also should evaluate expiratory pressure or peak cough flow, because this is highly important for secretion management. I will come back to this. And of course, we also can perform arterial blood gases, but as I already mentioned, daytime hypercapnic failure is rather late in the course of this progressive respiratory failure. So it's better maybe to evaluate parameters during the night or to rely on some other diagnostic methods also. ALS is a highly heterogeneous disorder, and in this paper, I will not go into detail, it was shown that based on some clinical features like age at onset, lung function parameters, and also genetic factors, patients could be categorized and the progression of ALS could be seen or could be defined. And this is of course important if we want to evaluate the exact or the optimal timing to start treatment or to start ventilation in these patients. So these kind of tools make individualized patient management possible and will also be important for possible future trial design. If we see there is hypoventilation in our patients, then of course we will try to treat or try to make this better for our patients. And in neuromuscular disorders, we will mainly treat respiratory failure with non-invasive ventilation. Of course, you can also intubate these patients, or you can place a tracheostomy and invasively ventilate these patients, but in the majority of patients, non-invasive ventilation is an option. And again, we should have also attention to support the coughing of these patients or to support the clearance of secretions, because this will certainly improve the efficacy of our non-invasive ventilation. Several guidelines have been published by different societies about when to start or what the exact timing of initiation of non-invasive ventilation should be. And you can see here guidelines from the UK or from European guidelines from the United States. You see that these guidelines differ somewhat in the exact cutoffs, but usually FVC, maximal inspiratory pressure, or blood gases are mentioned to define which patient we should start with non-invasive ventilation. This is a more recent guideline, and again, lung function tests, symptoms, blood gas criteria, or oxygen, CO2, and potentially sleep test criteria are included to determine this optimal moment of initiation of non-invasive ventilation. However, we should acknowledge, and these are data from a retrospective study in 624 ALS patients published some years ago, that NIV is usually initiated relatively late in the course of the disease. And this trial showed that the majority of the patients were already at a stage of symptomatic daytime hypoventilation. It also showed that in the majority of patients, there was a poor surveillance of the progression of the respiratory function. For example, FVC in seated position was only available in 66% of the patients. Respiratory muscle force tests was only available in approximately half of the patients. So I think we could do better. We could try to regularly perform these respiratory measurements to again find the optimal moment to start non-invasive ventilation. And it is important to timely start non-invasive ventilation because this retrospective study, for example, again in patients with ALS, showed that if you start patients rather early in the course of their disorder, so when the FVC is quite high, but 80% is maybe very high, but above 50%, and when you add also a cough assist device or a cough assist protocol to the treatment, then it seems that the survival for these patients is much better than when you start non-invasive ventilation rather late in the course of the disorder. And it seems again that the cough assist, the secretion management, is highly important because no cough assist compared to adding a cough assist also significantly improved survival after the addition of this cough assist device. So earlier NIV intervention is maybe important for patients with ALS, and this optimized protocol with the addition of a cough assist device or secretion management is highly important. In this study, it was a randomized controlled trial, again, in patients mainly having neuromuscular disorder. Patients were randomized after daytime titration of non-invasive ventilation in one group where a further sham titration was performed and another group that were further titrated using polysomnography. And it's after some weeks, patients were re-evaluated, and it seems that the average daily use was further increased significantly in the group that was titrated further with polysomnography compared to the control group where there was no significant increase in the average daily use compared with the daytime titration. So maybe not for all patients, but certainly for a specific group of patients where the average daily use is limited or who have persistent symptoms during the use of non-invasive ventilation, additional titration with a sleep test could be important. It was also shown that the number of asynchronies, mainly the ineffective efforts, was significantly reduced after this optimal PSG titration compared with the control group. We know, and we have a randomized control trial available from several years ago, that non-invasive ventilation can increase survival in patients with amyotrophic lateral sclerosis. And we also have shown, and these are data from Leuven, from our department, that non-invasive ventilation in these patients can improve sleep efficiency and sleep quality. And this is shown here in this figure where you have a patient sleeping suffering from ALS and having respiratory failure. You can see here the sleep or the hypnogram, where you see a lot of awake, where you see no deep sleep and no rapid eye movement episodes anymore. And 1 month after the start of non-invasive ventilation, you see a recuperation of deep sleep and recuperation of rapid eye movement sleep, and certainly improvement of nocturnal oxygenation. So NIV could certainly also improve sleep quality. These are data from a systematic review in children with neuromuscular disorders, again underlining the fact that survival can be improved with the start of non-invasive ventilation, that non-invasive ventilation has a significant effect on hospitalization rates and has, again, a beneficial effect on sleep efficiency. After the start of non-invasive ventilation in these patients, I already mentioned, it's important to monitor these patients and to follow up these patients. And the optimal way to monitor these patients during treatment with non-invasive ventilation is still under discussion. But again, different guidelines have been published how to monitor these patients. And this is one of these proposals where the authors say that, of course, we should look to symptoms and to clinical improvements. We could perform nocturnal oxygenation measurements, or we could also evaluate nocturnal CO2 or perform blood gases. But we definitely also should look to the data from the NIV software. So we have these data available. We can read out the device every time the patient comes, or nowadays we could even do it by telemonitoring or by consultation. And then based on these data, together with symptomatic improvements and or nocturnal oxygenation measurements, you have already quite a good monitoring of your patients. And what is important, of course, are leaks, because if leaks are present, you can often have also asynchronies and other events. So you should try to solve leaks by optimizing the mask fitting or optimizing the ventilator settings. If after these interventions there are still asynchronies or disturbing events, then a PSG or a new sleep test is warranted. And often, and this is a slide from one of our patients, again suffering from amyotrophic lateral sclerosis, we see often respiratory events occurring during treatment with non-invasive ventilation in these patients. And this is an example of one of these events. And here you see a fragment of a polysomnography with at the top the pressure delivered by the ventilator. You see the inspiratory pressure, expiratory pressure. You see the flow, and then the chest and the abdominal movements. And what you see is that the ventilator actually works. He delivers pressure, but no flow is going into the patient. So this means you should have a kind of obstruction here. But on the other hand, the chest and the abdominal belts are completely flat. So there seems also less effort of the patient. And these events are called obstructive events with a lower drive to breathe or a lower effort of the patient. And we see these events quite common in ALS patients. And this is a paper that described the occurrence of these patients, again, in a group of ALS patients having treated with non-invasive ventilation during the night. And these patients, this group of ALS patients was divided in group 1, a group of patients who were adequately ventilated, and another group was inadequately ventilated, defined by the occurrence of an oxygenation less than 90% for more than 5% of the nocturnal recording time. And then patients were further divided based on the occurrence of obstructive events, like I just showed, or the absence. And absence of obstructive events was defined as having less than 5 of these events per hour on the ventilator software. And you can see that when you look to patients who have obstructive events, even if they are adequately ventilated, or obstructive events despite adjustments of the ventilator, you can see that these two groups have the worst survival, while in patients who are inadequately ventilated with obstructive events, after adjustment of the settings, the events are abolished. These patients seem to do quite well with regard to survival. So it seems important to try to address these obstructive events, and these obstructive events appear to be important and having an impact on survival in these patients. With regard to NIV interface, Professor Schwarz already mentioned the importance of leaks for adaptive servoventilation. With regard to non-invasive ventilation, I would just like to show you this study, which was an observational study in patients with different underlying disorders, including neuromuscular disorders, treated with non-invasive ventilation with an oronasal mask and having an obstructive index of more than 15 per hour, despite quite high expiratory pressures. These patients were included in the trial and then were randomized, and one night with a nasal mask was performed and one night with an oronasal mask was performed. And as you can see, there was a significant reduction in the obstructive events during the night with a nasal mask, with having a more than 10, with a difference higher than 10 events per hour in 74% of the patients. So the conclusion of this trial was that the switch from an oronasal mask to a nasal mask is feasible and efficient in patients on non-invasive ventilation when upper airway obstructive events persist or appear despite high EPAP levels. And nasal masks, if well tolerated, should really be implemented also for long-term NIV use, even in patients with neuromuscular disorders. Okay, if we see problems, then we should try to intervene. And I already discussed obstructive airway events, and I also already discussed mask leaks. You can also intervene for patient ventilator asynchronies and of course also for excess respiratory secretions. But what is also important is that you train the patient and the caregivers on the technical equipment at home, and that you give practical advice on problem solving so these caregivers could solve problems when they occur at home during the night. And of course, for fastly progressive neuromuscular disorders, anticipatory planning and palliative care is also important. And I would like to end this part of neuromuscular disorders with the fact that we really need multidisciplinary care for these patients with neuromuscular disorders, because these patients require complex care, and this is best delivered in a multidisciplinary context with different expertise and different specialists, either caring for their part of the patient. And this is just a summary or an overview of the multidisciplinary management. This has been published for patients with ALS, just to show you that it's not only the respiratory symptom or the breathlessness which should be tackled, but also other symptoms like muscle stiffness, muscle cramps, hypersalivation, dysphagia or weight loss, cognitive and behavioral change, and so on. So we really need a whole team to adequately address all these issues in these patients with neuromuscular disorders. Okay, I would then like to move to a second topic of my presentation, which is obesity hypoventilation syndrome. And obesity hypoventilation syndrome is defined as a patient who is obese with a BMI of more than 30 kilograms per square meter, suffering from daytime awake hypercapnia with a CO2 of more than 45, and having also sleep disordered breathing without other known causes of hypoventilation like COPD, significant kyphoscoliosis, neuromuscular disorders, and so on. And with regard to this sleep disordered breathing, we can make a distinction between two phenotypes of patients with obesity hypoventilation syndrome. And the first phenotype are patients who have really a hypoventilation phenotype during the night, which means these are patients that have, during the night, episodes of sustained reduction of ventilation, sustained reduction of flow, sustained oxygen desaturation, which will be more pronounced during the rapid eye movement sleep again. Because I already discussed, this is the phase that the diaphragm need to do all the respiratory work, and this is the most vulnerable phase of the night. And if you look to oxygenation tracings in this phenotype of patients, then you will usually see this type of oxygenation curve, where you have quite preserved oxygenation during the night, but you have these deep desaturations mainly during rapid eye movement sleep. So this is the hypoventilation phenotype. On the other hand, and this is the case for most of the patients with obesity hypoventilation syndrome, we can have the hypercapnic obstructive sleep apnea phenotype. And essentially, these are patients suffering from severe obstructive sleep apnea. They have repetitive obstructive apneas, and there is a reduction of the ventilation during the post-apneic period. There is a short inter-apnea ventilation interval, which means that there is a limited ability to eliminate the CO2 load which accumulates during the apneic phase, and this is why these patients become hypercapnic. So this is the hypercapnic OSA phenotype, severe OSA, and when you look to the oxygenation of these patients during the night, you see this typical obstructive sleep apnea curve. And if we talk then about treatment of these patients and we look to the positive airway pressure therapies that are available, then we can either treat these patients with CPAP or BiPAP, non-invasive ventilation. And I will come back on this because we have to look to the phenotype of the sleep disorder breathing in order to determine which positive airway pressure therapy modality we will choose. Of course, weight loss strategies, physical activity, rehabilitation are also highly important in these patients with obesity hypoventilation syndrome. This is a randomized controlled trial, including new patients with obesity hypoventilation syndrome. And in this trial, only patients with a severe OSA phenotype were included. So they all have the hypercapnic OSA phenotype with an AHI of more than 30 per hour. And then patients were divided in a non-invasive ventilation group, CPAP group, and a control group, and then were evaluated after 2 months. And what you see is that on PCO2 outcome, you see that there is a reduction of the CO2 both in the NIV and the CPAP group compared to the control group, but there is no significant difference between the non-invasive ventilation group and the CPAP group. And furthermore, also sleepiness improved similarly in the non-invasive ventilation and CPAP group. And there was a similar improvement of symptoms like dyspnea, unrefreshing sleep, tiredness, nocturia, headache, and so on in patients treated either with non-invasive ventilation and CPAP. So no significant difference in the most important outcomes between non-invasive ventilation or CPAP in the hypercapnic OSA phenotype. On the other hand, this is another randomized control trial in the phenotype of pure hypoventilation. So these patients had no severe obstructive sleep apnea and AHI lower than 30. These patients were divided in a control group and a non-invasive ventilation group, and again evaluated after 2 months. And here it was shown that non-invasive ventilation could significantly reduce CO2 levels compared to the control group, and had also significant beneficial effects on symptoms like unrefreshing sleep, tiredness, compared to the control group with lifestyle modification. So if we talk about positive pressure treatment in patients with obesity hypoventilation, then the question is not should we use CPAP or BiPAP for all the patients, but we should look to the phenotype of sleep disorder breathing in a specific patient. And if we see this phenotype, the hypercapnic OSA phenotype, then we can start CPAP as it was equal to non-invasive ventilation, and it's more easier to use. If we have a patient with pure hypoventilation, then we should start non-invasive ventilation or BiPAP. Of course, if after a few weeks or months of CPAP treatment in this patient, you see there is no improvement of oxygenation or CO2 levels, then you could consider to step up from CPAP to non-invasive ventilation or BiPAP. And this is a more recent guideline actually mentioning the same. So we should perform a sleep study or a sleep study within 3 months after an acute respiratory failure event to determine which phenotype these patients have. If they have severe OSA, then we can start CPAP. If they have no OSA or only mild or moderate OSA, then they are the hypoventilation phenotype, then we should start non-invasive ventilation. Here, they go one step further. You can have a hospitalized obese patient who has acute on chronic or acute hypercapnic respiratory failure. It is proposed to start non-invasive ventilation in the acute phase and discharge the patient with a ventilator if possible. But then after a few months, the patient should come back when he is more stabilized to perform the sleep study and determine the type of sleep disordered breathing. And of course, besides this positive airway pressure therapy, I already mentioned weight loss strategies, physical activity, rehabilitation is highly important to have an holistic approach to our patients. And also we should have attention for comorbidities like hypertension, diabetes, and other metabolic diseases, which should adequately be tackled in these patients. So for the last part of my presentation, I will shortly mention something about sleep disordered breathing, but actually focusing on hypoventilation and COPD patients. And we already discussed that during sleep and mainly during REM sleep, there are significant changes in all of us, like changes with respiratory control, with reduction of chemoreceptor sensitivity. There is a reduction of respiratory muscle function during rapid eye movement sleep, with all activity or main activity be performed by the diaphragm. We have a reduction of the upper airway muscle activities, which could lead to a higher upper airway resistance. And in COPD patients, of course, also lung mechanics are sometimes comprised. So this could lead during sleep to development of nocturnal hypoventilation, hypoxemia, and hypercapnia. And if we have a patient with chronic hypercapnic COPD, so outside of any acute exacerbation, then we could also consider maybe the treatment with nocturnal non-invasive ventilation. And in 2014, a meta-analysis or a review was performed to determine the effect of non-invasive ventilation for patients suffering from chronic hypercapnic COPD. And it was concluded that non-invasive ventilation during the night for 3 or 12 months in these patients had no effect on gas exchange, exercise tolerance, quality of life, lung function, muscle strength, or sleep efficiency. So it seemed that there was no significant effect. However, during that time, there was some interest, mainly in some German centers, in so-called high-intensity non-invasive ventilation. And high-intensity non-invasive ventilation is normal non-invasive ventilation, but aimed at achieving normocapnia, or if hypercapnia cannot be totally avoided, the lowest possible CO2 values that are tolerable for the patient using quite high ventilator settings. And if you compare the studies that were included in the former review in the previous slide, then you see that inspiratory pressures between 10 and 18 were used in most of these studies. If we talk about high intensity NIV and some studies that have been published with these settings, then you see that inspiratory pressures were much higher, with a mean of 28, even going higher in certain studies, and that also the backup frequency was quite high. So really aiming for a really high intensity of non-invasive ventilation and a maximal reduction of CO2. And with this high intensity and non-invasive ventilation, a randomized control trial was performed by a German group of researchers in COPD patients with severe COPD, GOLD 4, who were clinically stable, but despite that, were suffering from chronic hypercapnia with a daytime hypercapnia of more than 53 millimeters of mercury and with a normal pH, so no acute exacerbation. These patients were randomized in a control group or in a non-invasive ventilation group. And here you can see the survival after 1 year. For the intervention group in red, there was a significant reduction of mortality or a significant improvement of survival. So in the treatment group with non-invasive ventilation. And in this group, there was also a significant improvement of respiratory symptoms. In another trial, again, in patients with chronic hypercapnic COPD, with severe COPD, clinically stable patients, but now 2 weeks after an acute exacerbation, having still a CO2 of more than 53 millimeters of mercury, patients were again randomized between the control group receiving home oxygen therapy alone or the home oxygen therapy plus home non-invasive ventilation during the night. And you can see again that for the second trial, the admission-free survival was significantly improved after 1 year in the group with non-invasive ventilation. So we now have actually 2 randomized control trials showing some benefits in survival and admission-free survival in patients suffering from stable hypercapnic COPD. Now I would like to conclude with this slide, which is an individual patient data meta-analysis of several randomized control trials evaluating the effect of non-invasive ventilation versus usual care in COPD patients. And the conclusions of this meta-analysis were that higher inspiratory pressures, but certainly also better adherence to NIV, is indeed associated with larger reduction in CO2 levels. But it seems that when you are talking about outcome of quality of life, that the severity of airflow obstruction and the ventilatory impairment is not really associated with the effect of NIV on quality of life. However, in patients who have frequent exacerbations, more than 3 per year, here less quality of life benefit is to be expected with treatment with non-invasive ventilation. It was also concluded that the beneficial effect on quality of life is only partially achieved through a reduction of the CO2 levels. So also other factors are quite important to establish an effect on quality of life in these patients. So to conclude, the development and progression of respiratory failure is highly variable in different neuromuscular disorders, and therefore patients with neuromuscular disorders should be screened for nocturnal hypercapnia. The appropriate time to start non-invasive ventilation remains unclear, but recent data suggests that maybe early initiation may provide additional benefits, and the efficacy of NIV should be evaluated using objective assessments. For patients with OHS, obesity hypoventilation syndrome, the best treatment modality depends on the phenotype of the sleep disorder breathing. And high-intensity NIV or NIV with higher intensities has promising effects in selected group of COPD patients suffering from chronic respiratory failure. So I also maybe would like to end with one case. I think I have a few minutes left. So just to underline the importance of monitoring when you have a patient treated with nocturnal non-invasive ventilation. And this is a female patient suffering from amyotrophic lateral sclerosis who several years ago came to the emergency department because of respiratory failure. And you can see based on the arterial blood gas analysis, it was certainly chronic respiratory failure with a PCO2 of 68 millimeters of mercury during daytime. So it was decided that she was moved to the intensive care unit to start non-invasive ventilation. Here you see the settings. But after 3 nights, the ICU called us, the doctors at the sleep lab, and asked for a transfer to do more monitoring because the CO2 was still 60 millimeters of mercury and it was very difficult to ventilate this patient. So these were the settings during the first night in the sleep lab: an oronasal mask with a spontaneous timed mode of an inspiratory pressure of 16 and a frequency of 12. And we performed a nocturnal polysomnography in this patient. Here you can see the sleep. So she was awake for quite some time during the night. She also removed the non-invasive ventilator during several hours during the night. You see the oxygenation with a large amount of desaturation. And here you see the CO2 levels, which indeed were approximately 60 to 70 during the night, despite being ventilated for a large part of the night. When we look more closely, then you see here the pressure of the device with the positive and the inspiratory and the expiratory pressure levels. Here you see the chest and the abdominal belts and the saturation. And you see that there are different respiratory events which seem to be a kind of obstructions because the device is giving pressure, but air is not really going into the patient. There is less chest movement in these patients during different periods. And when we then look to the video of our patient, and I don't know whether it's completely clear, but you should have a look to the tongue, you see that intermittently during the inspiration, the tongue moves backwards and is actually blown into the throat of the patient. And this backward movement of the tongue actually causing an obstruction in this patient. So after seeing this, we changed the mask to a nasal mask, and we actually reduced the inspiratory pressure a little bit, and we evaluated the second night, and this was the signals we saw during the second night of monitoring with the nasal mask. So you see very much an improvement of the signals. You can see a summary. So you see the arousal index was significantly reduced during the second night. Apnea-hypopnea index was also significantly better, and the mean saturation was significantly improved, and also CO2 was highly improved during the second night with the nasal mask. So just to underline that close monitoring of these patients is important, and again to remind you that ventilation with a nasal mask is possible in these patients with neuromuscular disorders. So thank you for your attention.
I was trying to activate my microphone. Thank you, Dries, for this highly educational and scientific-based presentation. You cover efficiently a huge topic, highlighting the need for early identification of patients with hypoventilation of specific origin, the proper diagnosis and phenotyping also of these patients, and the art of choosing the proper PAP or NIV mode, but how importantly you follow up also the patients and not only in the course of the disease, but also the importance of initiating the non-invasive ventilation and the role of mask fitting and the proper mask for the patient also, and the importance of the nasal masks to overcome problems like the one you saw in this case. Thank you so much for this. We have a question from Katerina Vlami, is one of the two coordinators of the sleep in Hellenic Thoracic Society, and Katerina asks if in clinical routine is a good practice to evaluate patients with neuromuscular disorders with noctular capnography and oximetry from the very first moment in order to rule out sleep hypoventilation, which is the first sign of the disorder which needs NIV. Again, this question is towards early identification, and I would like to add the role of bicarbonates also, which is not of metabolic origin. Thank you.
Okay, thank you for this question. Of course, in an ideal world, we could maybe perform nocturnal capnography oximetry from the beginning on and do it regularly, but usually this is not feasible. So we should select maybe a moment that we maybe think there is a high suspicion of having nocturnal hypoventilation, and that's why we routinely rely on these lung function measurements or respiratory muscle force measurements. Of course, also symptoms of patients are highly important. If a patient suffers from specific symptoms like orthopnea or sleepiness during daytime, then we of course will do more easily a sleep test or a nocturnal evaluation of the oxygen or CO2 levels. But this is a little bit how we work. We see the patient every 3 months on the consultation. We do systematic lung function measurements. We evaluate symptoms. We often also do blood gases, mainly to look to the bicarbonate levels, as you say, as you mentioned, because CO2 levels will come later in the course, usually after the development of nocturnal hypoventilation. And if we are in doubt or we are not very sure whether there is already nocturnal hypoventilation, we will ask for a sleep test or do a nocturnal monitoring in this patient.
Thank you so much, Dries. And with this, we would like to conclude this important webinar. Once again, thank you so much, Dries and Esther and Dries, for your contribution. Highly appreciated. We will keep in touch with the Hellenic Thoracic Society in the future also, or in national or European congresses as well. And a huge thanks to the participants as well for their presence here. We overcome the problem with the football because we have a high rate of attendance. And once again, thank you so much for your contribution. And of course, the webinar will be available in the e-learning platform of Hellenic Thoracic Society. And a huge thank to our supporter, to the organizer of this virtual meeting. And that's it. Have a nice night. And thank you again so much, both of you.